So here I'm going to outline the updates on obstetric sepsis management and a couple of new updates in definitions. Okay, so the learning objectives to understand the definition and epidemiology and to recognize the risk factors and the clinical presentation, how to diagnose sepsis and how to screen, and a few early warning systems I've introduced, and the management. So is it common? According to Embrace, yes, global burden is about 11% of maternal deaths are due to maternal sepsis. So it is 1/10. The incidence reported between about 0.04 to 0.1%. It is low, but the most important fact here is it is a preventable cause. If we identify, as Dr. Shamila mentioned, if we recognize it, we can treat it and we can save a life. So that is the important thing. So what is a maternal death? It is a death of a woman while pregnant or within 42 days of the end of pregnancy from any cause related to aggravated by the pregnancy. But remember, the accidental or incidental causes are not included here. According to Family Health Bureau, this is the maternal mortality ratio in Sri Lanka. That means the death for 100,000 live births. It is around 40s from 2000 to 2023. So these are the causes for maternal deaths. The most common cause here in Sri Lanka is obstetric hemorrhage that we all know, and then the respiratory and hypertensive disorders, and the fourth one is the sepsis. What is a maternal sepsis, or what is the definition of maternal sepsis? So sepsis 3, according to the sepsis 3 or WHO definition, it's a life-threatening condition defined as an organ dysfunction. I will mention what is an organ dysfunction, resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. So what is this organ dysfunction? It is, we go through the SOFA score. I will show you that. If it is 2 or more, we take it as the organ dysfunction. And what is the septic shock? If the hypotension is defined as MAP less than 65 mercury millimeters, which need vasopressors, and lactate more than 2, despite adequate fluid boluses. So this is the SOFA score. It has 6 domains, starting from the respiration, that is the oxygen index. We know P8O2 divided by F5O2. We can get the value. And the coagulation is simply measuring the platelet count, and the liver by measuring the bilirubin. Cardiovascular system by the blood pressure, mainly the mean arterial pressure, whether the patient is on vasopressors, and neurological by what we all know, the GCS score, and the renal by assessing the serum creatinine. There's something called QSOFA. It is an easy bedside scoring, again, a tool. There are obstetrically modified score. You can remember it as HAT, H for hypotension, that is systolic blood pressure less than 90, respiratory rate, and altered level of consciousness, respiratory rate more than 25. So what are the causes? There are uterine causes as well as extrauterine causes. Most common one is the chorioamnionitis. It's about 50%, nearly 50%, and endometritis, an infection of the genital tract. And pneumonia, we all know, we had this COVID, viral pneumonia, or any other conditions, bacterial pneumonia, UTI, pyelonephritis, and postpartum period, surgical site infections are also common. Organisms, the most common organism is E. coli, but the most virulent one is group A beta hemolytic streptococcus. About 50% of deaths due to maternal sepsis are due to GAS. And group B, beta hemolytic streptococcus, anaerobes, Staph aureus, coliforms, H. influenza are also causative organisms. So what are the risk factors? We can divide risk factors into obstetric and medical. Obstetric risk factors are multiple gestations, preterm delivery, premature rupture, induction of labor, and the procedures such as cesarean sections, removal of retained placenta are giving rise to are high risk for infection. So we usually use prophylactic antibiotics. We can discuss it later. And stillbirth, postpartum hemorrhage, terminations, and maternal GTM is also taken as an obstetric risk factor. So what are medical risk factors? Any chronic illness like anemia, heart failure, liver disease, renal failure, obesity, and immunocompromised mothers are high risk to get a sepsis infection. Okay, so the recognition is the most important thing. So think sepsis is very, very important, or suspicious and prompt action is the key here in sepsis, not in the maternal, any sepsis, that is very, very important. So if you get a mother repeated presenting to you, or general practitioner, or a community midwife, or repeated self-referral, we have to think about this sepsis as well. 18, according to this study, 18% of patients were febrile on presentation. The important thing is quarter, or the 25% never develop a fever. So what does it mean? It means, so we can't easily identify or recognize sepsis by simple things. And on top of that, we all know the physiology of the pregnant mother is also overlap with the criteria, SIRS criteria, tachypnea, tachycardia, even the temperature are overlapping with the mother's normal physiology. So how can we identify, or how can we recognize it early? Using these tools. There are so many tools introduced worldwide. We all know in general setup, we use this new score, early warning scoring system. For maternal early warnings, there are so many maternal early warning scoring systems modified specifically for obstetric patients. Modified early obstetric warning score is currently used in Sri Lanka. We will explain it later. And maternal early warning triggers, sepsis in obstetric score, any scoring tool, most of the scoring systems are validated, so you can use any of them in any, institute-wise, we can decide that. So what are the things included here? Respiratory rate, saturation, temperature, systolic blood pressure, diastolic blood pressure, heart rate, conscious level, discharges, proteinuria. So simply to identify or early recognition to see whether the patient is deteriorating. So this is showing a modified obstetric early warning score, which we are using in Sri Lanka. Same things. We monitor and document every 15 minutes. We can put a tick, and there are scores according to the number. It is color coded. In detail, we will discuss when we are doing the case discussion. And MEWT, which we are not using much, but it is also a validated tool, not only to recognize sepsis, but other conditions like hypertension, cardiopulmonary issues, and hemorrhage as well. So, so if you go through the evidence, those tools, by using those tools, we can minimize deaths as well as morbidity. Okay, so why we are using this? To identify. So how can we escalate according to the number, or according to the according to the score? So red flag is known as the early warning score more than 7 and 7 and above. So the patient might go to the ICU. So I will quickly go through the numbers we are thinking when a mother is having red flags. Features are GCS less than 15, so 14 also a red flag sign, respiratory more than 25, saturation less than 94, heart rate 130, blood pressure systolic less than 90, uh, urine output, no urine output for last 12 hours or less than 0.5 ml per kg per hour. So remember these features. So these are red flag signs. So your mother, the mother with the sepsis should be treated promptly and maybe in an ICU care. So there are amber flag signs as well. So you have to early act, uh, probably taking blood cultures, investigations, and starting antibiotics. So what are those things? Respiratory rate 21 to 24, heart rate 200 to 130, systolic 90 to 100, and with history of cesarean birth, any procedures, immune compromisation, temperature, low temperature, high temperature, diabetes, GDM, and contact history. With those risk factors, we have to label them as amber flags. So the patient might monitor in an HTU care. Okay, so what are the investigations for suspected sepsis? Uh, we need to obtain blood cultures, two sets of blood cultures before starting antibiotics. And we have to start antibiotic without waiting for the microbiology results and consider viral. If you think viral, you can send for PCR testing. We all know with this COVID era, we had this experience. And it is very, very important to measure lactate. Lactate more than 4 means you have to immediately escalate of the care to a critical care unit, I mean the ICU. And to perform, you have to identify the source. So it is important. So imaging studies like pelvic ultrasound, CT scan, chest X-rays, you can consider. So you don't want to avoid taking chest X-rays if you think it is going to helpful in your management. Um, so taking microbiological samples, relevant samples. So with patient with a cough, we might take sputum samples, with fevers, blood samples, or any other wound cultures. It depends on the situation. And other basic investigations, full counts, coagulation profile, blood urea, serum electrolyte, renal functions, and the liver functions, and the CRP, and venous blood gas, and RBS. In virological testing, if you are suspecting like COVID or tonsillitis, pharyngitis, you may do throat swabs. And for MRSA, status unknown, or if you suspect, you may take nasal swabs as well. So this is important slide. It is introduced by the Surviving Sepsis campaign. So if you recognize a mother having a sepsis, these 5 steps, very, very important. So that is the initial resuscitation for sepsis and septic shock. So what I'm going to do, measure lactate and take blood cultures before starting antibiotics, but don't delay, administer broad spectrum antibiotic and rapidly administer 30 ml per kg crystalloids, so about 1.5 to 2 liters for hypotension, or if the lactate is more than 4 millimoles per liter. And if the patient is not responding, you may immediately start vasopressors or after fluid resuscitation to maintain mean arterial pressures more than 65 mercury millimeters. And remember to remeasure and remonitor patient's lactate. So what is this lactate? It indicates the organ hypoperfusion, and it can be a sign of viscous injury. And remember, this has a link. This has a link to mortality rate. So if the lactate is 4, the mortality rate can rise to around 28%. I will quickly outline the management again. So remember, you can't do it alone. So it should be a multidisciplinary approach. That's why we have a esteemed panel today as well. So senior clinicians, your senior obstetrician, obstetric anesthetist, and the microbiologist input, and all the other relevant expertise should be taken. And urgent urgent referring to, I mean, the escalating to HDU, ICU is important. That's why we are using early warning score charts and fluid resuscitation. You can give a fluid bolus, maybe 500 ml, and you can reach up to around 30 ml and you can start an vasopressor immediately. An empirical antibiotic will go through in the case discussion. In life-threatening sepsis, we can start a broad-spectrum antibiotics, piptas or meropenem, with or without clindamycin, and MRSA risk or history, we may add vancomycin. When we get the culture reports, we can de-escalate always to target oral therapy subsequently. And deterioration continues despite first-line antibiotics. We may also consider a cyclo 500 milligram 8-hourly. I think our microbiologist, Dr. Mahen, will explain a little bit more about what to start when we suspect antibiotic infections. Sepsis 6 also. This is a guideline which has introduced a few years back. So you can use this as well in ward setup. So one is to ensure the senior clinician attend. That means obstetrician or relevant people should review the mother, and oxygen to maintain saturation 94 to 98, IV access, take the blood, cultures, all the investigations I mentioned, and starting crystalloids. And giving antibiotic after taking cultures and fluids. According to sepsis 6, it is 20 ml, but you can go up to 30 ml per kg. And the last one is monitoring, including the early warning scores in system. So these are the source and the relevant antibiotics. I'm not going to go in detail. So for MRSA, we can start with gentamicin. Anyway, I will leave these two microbiologist opinions. So we'll go to, right, where should mothers stay after diagnosis sepsis? So it doesn't matter, but it is, I mean, according to the early warning score in system, if it is more than 7, the patient can go to the intensive care unit. But there are pros and advantages and disadvantages as well. So staying in a labor ward, the monitoring is difficult. So early recognition, early escalation is difficult. But as we all know that obstetric, if there's a maternal patients, we all are not expertise. I mean, as anesthetists, we are not expertise in the obstetric part. So medications, if the diagnose the fetal issues, and the patient might away from the operating theaters. So those things also there. So it is we have to decide then and there. Some antibiotics are avoided, better to avoid, like streptomycin, tetracycline, and tetracycline, simply because of the fetal toxicity. So when to transfer the patient to ICU? If there's any organ dysfunction, we might observe the mother in an HDO or an ICU, like hypotension, as we discussed, systolic less than 90, serum lactate more than 4, respiratory any condition, any worsening condition in the respiratory system, or if the mother needs ventilation, definitely she will go to an ICU. Renal replacement therapy, decreased level of consciousness, and uncorrectable acidosis, hypothermia. What is the place for IV immunoglobulins? So it is just beneficial in gram-positive necrotizing infections, toxic shock syndrome, and suspected gram-A streptococcal sepsis. This actually helps to neutralize the exotoxins and reducing superantigen activities. So when we admit clindamycin, it says, according to the evidence, it says there is an synergistic effect. But remember, this is only recommended when the conventional treatment is failing and patient is critically ill. Remember, mother is not alone, so we have to look after fetus as well. So otherwise, we might deliver, or we might get a baby with an encephalopathy or cerebral palsy. So yes, we can consider corticosteroid, even the mother is having sepsis for the fetal lung maturity, and also magnesium sulfate is not a contraindication in sepsis, which we are using for fetal neuroprotection. Continuous ECTG recommended in any mother with pyrexia, fever, or suspected maternal sepsis even without fever. Delivery decision will be taken by an obstetrician according to the patient's illness, fetal well-being, gestation age, labor progression, and maternal preference and response to treatment. So what is this ECMO? So it can be the ultimate resort if the mother is not improving with our conventional and our other methods. In severe ARDS, refractory hypoxemia, septic cardiomyopathy, persisting lactic acidosis, we can consider ECMO. Unfortunately, we have only one institute with ECMO support. So take home message, be aware of sepsis and beware sepsis. So why? Because sepsis is difficult to identify, but if we identify, we can treat and we can save a mother. And beware because it is too dangerous. If we don't treat, remember if we delay giving antibiotics, so mortality rate increase by a significant percentage. And if sepsis is suspected in the community, urgent referral to an hospital and further escalation is important. And what we need to remember is early antibiotic, fluid resuscitation, measuring lactate, re-monitoring, and early multidisciplinary team approach. So remember this triad. So this is to improve our sepsis outcome in any setup. There's simulations to improve our teams, training, skills, communications, and also we have to we have to train, educate the mother, patient, because it comes from the mother. The patient is the one first going to suspect that he is having some problem or the sepsis. So we have to teach them, and the cognitive aids like checklist algorithms and the early warning scoring systems, which we are going to discuss. These are my references. Thank you very much.
Thank you, Dr. Roshana. Let me invite Dr. Alex to continue.
Yes, madam. I will share my presentation now. I think Roshan sir should stop this sharing the screen.
Yes.
To share. This is my, I'm going to start the presentation. Before that, I want to confirm the screen is visible to everyone.
Yes, we can see it.
And is it moving?
It is moving.
Okay. So first of all, thank you. I'm Dr. Alex, SR Anesthesia, currently working at Lady Richard Hospital, attached to the NHSL group. And I'm going to discuss the case regarding the maternal sepsis. Before that, I have to invite our panel consultant for this case discussion, Dr. Chintaka Banakula sir, who is the consultant obstetrician and gynecologist at DMH Profini, Dr. Shamita Dasanayaka, consultant physician at Castle Street Hospital for Women, Dr. Mahen Kotlawala, the consultant microbiologist attached to NHSL, and Dr. Iresha Valavagi, the consultant anesthetist at Castle Street Hospital for Women. And I thank the College of Anesthesia for giving me this opportunity to do this presentation. So I'm going to start this case presentation. Before that, I have to make a statement that the maternal sepsis can be occur in the antepartum or intrapartum or postpartum period. So my case mainly focus on the postpartum sepsis. Anyhow, in during the presentation, we will discuss with our panel members regarding antepartum sepsis also, then and there. Okay, I'm going to start the presentation. So this is the case history. A 24 years old primary gravida who underwent emergency section for dribbling and the fetal distress and thick meconium. So it's kind of urgency. Her antepartum period was not significant and the surgery was uneventful, the cesarean section. So the estimated blood loss is 350 ml. So it's quite usual for the normal cesarean section. And IV cefuroxime 1.5 gram and IV metronidazole 500 milligram was given as a surgical site infection prophylaxis. And she was sent to ward after post-op care from 30 minutes from the recovery unit. For the pain, she was prescribed paracetamol 1 gram 6 hourly and the diclofenac sodium 50 milligram BD and morphine 5 milligram subcut SOS. At the ward, on the post-op day 1, she had a mild PV bleeding, no any other symptoms. For that, otherwise she is healthy and looks well and alert, responding. So it was managed with tranexamic acid 1 gram and was settled on the same day. And IV antibiotic was converted to oral antibiotic as a unique policy in the hospital. On post-op day 2, she developed the fever spike, 38.2 degrees Celsius. So in this point, I want to clear my doubt to the Chintaka sir. Is it significant? Because usually following the surgery, patient may have fever, maybe due to the surgical stress response, or maybe due to the actual infection. So in this stage, what we should do to manage this patient? Chintak sir. Hello, sir.
Yeah, Alex, can you hear me?
Yes, sir.
Yeah, Alex, actually now this patient had an emergency cesarean section. If you go back to the history, it's like she had dribbling. We don't know the exact duration of dribbling. That means the rupture of membrane. So rupture of membrane is always a risk factor towards postpartum infection because it gives access for the vaginal ascending infection into the endometrial cavity. So, given that history, developing fever actually on day 2, because if it is stress response, even you will see a minor temperature elevation in the first 12 hours or so, or maybe maximum up to 24 hours. But to have fever on day 2, and given the history of this scenario, it is more likely an infective reason rather than any other reason. Sometimes epidural also, if they are on epidural, then can have about point half a degree Celsius increase in temperature. But always postpartum fever or postpartum pyrexia we consider as a significant feature. They might not all of them go into sepsis, but they can be only localized infection. But it's very important us to collect all of them and assess them properly to screen what they're actually having. So in this situation, given the cesarean section and the risk factors she was having, I would say it is an important finding to have fever of 38.2 degrees.
Okay, sir. Thank you, sir. So on clinical assessment at the ward, she was alert and responding. On and off dry cough is there. Respiratory rate is 15 breath per minute. Lungs clear. Saturation was maintained 98% on air. She had a heart tachycardia. The heart rate is 110 beat per minute and good volume. The blood pressure 110 by 70 millimeter mercury and the capillary refilling time less than 2 seconds. Urine output good. So these parameters indicate she had an adequate fluid status. And abdomen was soft on palpation and mild tenderness at the lower abdomen at the site of surgery, but no bleeding or no discharge from surgical site or through the vagina. Her initial investigation revealed WBC is 17 that was increased to 90 and hemoglobin change not significant. Hemoglobin 10, platelet 176, electrolytes serum creatinine normal, but the CRP is increased significantly from 24 to 254. So I want a clear doubt about with Mahen sir whether we can label as a sepsis of this sepsis in this stage for this patient. Mahen sir?
Yeah, thank you. Can you hear me?
Yes, sir.
Yeah. So now considering the patient's presentation and the clinical parameters, if you take the clinical parameters and the presentation alone, the details are not enough to say this is sepsis. But if you focus on the last investigation, that is CRP rise within 24 hours, 24 to 254, it is very critical. So that rise within 24 hours, rise of 230. So that itself is a very warning sign. So now we call it CRP velocity. So now the CRP velocity has exceeded 10 units per hour. So that is very critical finding. And if you take that alone, you can call it some sort of a warning signal is coming. Most probably the patient is in the verge of sepsis, although clinically there's no evidence to show that the patient is having any sort of a organ dysfunction.
Yes, sir. Thank you, sir. And we have in the ward, the investigation was done are the blood culture and high vaginal swab culture, UFR and urine culture. And dengue antigen also taken because of we are in the critical state. And so we are in vulnerable to the dengue fever and it also common in pregnant patients. So we have done the dengue antigen and also patient have the cough. So we have taken the chest x-ray and we have converted the oral antibiotic to IV antibiotics, cefuroxime and the metronidazole. It's the same antibiotic initially we give for the surgical site prophylaxis, and during the ward stay we converted into oral, and because of the CRP increase, we converted back into IV form. So, Mayank sir, again, do we need any further investigation to find out the source of infection? And other question is whether this antibiotic coverage is adequate at this stage, or we need to go for the escalation. Mayank sir?
Yeah. So I will start with the investigation part.
Yes, sir.
So far, I think you have covered almost all the investigations. Now, this is a patient in post-operative day 2. So the investigation-wise, for me, to get some idea about her status, so those are okay. As for the antibiotics, still patient is not in the verge of sepsis and septic shock, that region. So therefore, still I would say the current antibiotics are okay, and there is no need to panic about escalation of further. And this will have a good coverage, especially considering the patient's surgery and the intra-abdominal condition. So I would say the current antibiotic coverage is okay.
Okay, sir. And other things, sir, we are doing nowadays the procalcitonin investigation. Is that necessary in this test, sir? Because CRP is 254 and patient have the fever. So we have taken all the cultures. Is this necessary to go for the procalcitonin investigation as a first
So
line?
no, at this moment, because we have noticed the critical increase of CRP level. So that is, if you are interpreting CRP level carefully, so it will be as sensitive as procalcitonin in when you want to take a crucial decision. So therefore, with the series of CRP values, I don't think procalcitonin is not needed in this situation. And other thing is procalcitonin is a bit costly for
Yes, sir.
hospitals, and it is not available at all places. So therefore, CRP rise would be enough for this patient.
Okay, sir. Thank you, sir. So, as we have already discussed the Muse chart, that is very important in the to find out the pregnant patient for early deteriorating condition. So Muse chart means the modified early obstetric warning system. So it is the tool that is recommended in sepsis 6 to find out the sepsis in pregnancy. It can be used in multiple setups, such as postpartum hemorrhage, any emergencies we can use. That means this is not only specific for the sepsis. Any deteriorating patient, obstetric patient, we can use this score. And the sepsis 6 also recommended use this scoring system for the maternal sepsis. So it helped to identify early recognition and maternal compensation mask shock, because we know the physiological changes in the pregnancy will mask the shocks. They have the good volume of pulse all the time, and peripheral usually warm and flush, and their heart rate is usually high, and the blood pressure marginal. So these kind of physiological symptoms will mask our deteriorating patient during the shock. So this warning system will use to identify the early deteriorating patient, and it used to escalation for the management. And also it prevents the delayed transfer to the ICU, where we can observe the patient continuously. So this is the early warning systems for the maternal patient. Here we can see, according to the Muse score system, we can have a plan of management. So it should be monitor ABCDE approach. There are parameters that already discussed with the Roshan sir. And the monitoring part, they have recommended in first hour every 15 minutes, next 2 hour every 30 minutes, next 24 hours every 4 hours. And further monitoring should be decided by the physician. And according to the score, the total 0, we can continue the same monitoring 8 hourly. If the score is 1 to 4, it means there is a low risk. So we have to monitor 4 to 6 hourly, and patient should be reviewed by the senior nursing in charge, and inform the medical officer who should attend within 1 hour. So in our setup, the intern medical officer should be informed. And if the patient have 3 in single parameter, again it's low medium risk. So we have to go for the hourly monitoring. The medical officer should be informed. And the 5 means the medium risk. Again, the senior medical officer should be informed. It can be a SHO in our setup, or we have directly called to the consultant to avoid unnecessary delay in the management. And in this stage, we have to go for the ADU ICU care, because we have to monitor the patient hourly. And if the total score is 7, that means very high risk patient. So in this setup, we have to go for the multidisciplinary team approach. I think the multidisciplinary team approach should come early. In this stage, we have to have, and the ICU team should be involved for the continuous monitoring and optimization of the parameters and the physiological parameters. So in our patient, in this stage, she had the Muse score of 2. So according to this, the plan of management what we have done, they inform the midwife, increase frequency of monitoring, inform the doctor, and escalation if needed. So this is the plan of management according to the Muse 2 we have to do. Okay, on the post of day 2, she again had high fever spike, and the cough worsened now, because initially she had only mild cough. Now it was worsened, but not sputum productive. Respiratory rate increased to 23 breath per minute. Bilateral basal occasional crepitation is there. The patient increased work of breathing. Meantime, the saturation dropped to 93% on air. The heart rate is 120 beat per minute. Good volume. Blood pressure is adequate, and the capillary filling time normal. Urine output adequate. The abdominal soft, and again she had a mild to moderate tenderness at the lower abdomen, but no bleeding or discharge. And she was started oral feeding at the womb. And they have repeated the investigation. Again, the WBC is still again increasing, 19 to 21. And CRP is 254 to 274, still increasing very high. And the serum creatinine also now increasing, 54 to 60. So usually in pregnant patient, the serum creatinine, the borderline, the upper limit of serum creatinine is low compared to normal people. So we have to consider that also. So in this stage, we have done the investigation. The report has come. The UFR shows there's a field full of pus cell and occasional red cells. And the blood and urine culture, negative. HBS culture, high vaginal swab culture, the group E hemolytic staphylococcus is positive. Chest X-ray was done and it reported by radiologists, it was normal. And the dengue antigen was negative. So in this stage, do we need an ABG? Yes, because in this stage, patient have the respiratory problem. So to identify the oxygenation and the acid-base balance, we have to do the ABG. So it was done. It was mentioned the pH is 7.52, mild alkalotic side, and the PCO2 is 22.2. That means this is respiratory alkalosis, most possibly due to the hyperventilation. And the partial pressure of oxygen is 84 on air, and the PF ratio is 400. So it means that the diffusion part of this lung is not affected at the moment. The bicarbonate is 20.4, base excess minus 1.6, and lactate 1.0. So this is show the compensation for the respiratory alkalosis. So we have think that this is the not a significant change we have observed in this other than the hyperventilation. So in this stage, the what team plan to do the opinion. So they have planned to get the opinion from the consultant physician and the microbiologist. So the physician suggests to do the 2D echo, venous duplex scan, and influenza mycoplasma screening and procalcitonin, and ultrasound abdomen. And salbutamol ipratropium nebulized solution also started. So in this stage, we have to ask Samita sir, is these actions is correct and necessary for to manage this patient? What is coming to your mind, sir? Because patient after surgery, patient have the fever, and the patient now have a features of respiratory tract infection. ABG was shows not that much affect the diffusion part, and chest X-ray normal. Meantime, she had a high vaginal swab culture positive. She is on IV cefuroxime and the flagyl. What do you think about this condition, sir? Shamita, sir?
Yes, can you hear me?
Yes, sir.
Yes. Now, when the patient was referred to the physician, this is day 2 fever, postpartum period, and there are some hard facts. One is the patient is having respiratory distress, the saturation is dropping, and evidence of bilateral basal crepitations, even though the X-ray is normal. And other parameters, when you go through blood investigations, the white cells are rising, CRP is rising, but the platelets are dropping.
Yes.
Right. So then we need to, again, the basics are very important. So first thing, we should go to the patient and have an assessment and ask about the history. Because these days there are two common infections, respiratory tract infections that we are dealing with. One is the influenza, the other one is the mycoplasma. So if the mother is having a influenza infection, you will get all the wet symptoms like the sore throat, blocked nose, runny nose, sneezing, wheezing, those things. But if the mother is having a mycoplasma infection, then the mother is usually having a dry cough. But both of these conditions can give rise to respiratory complications, including pneumonia. So when you come to this investigation point of view, first I will go for do the blood picture on this patient, because this is very, very important to do a blood picture to get maximum information. When you're doing a blood picture, the white cells will say whether I'm dealing with a viral infection or a bacterial infection or both. Because sometimes the viral infection and there may be other bacterial infection also there. So then I have to be very cautious whether I'm dealing with viral or bacterial. And the second thing is I can get some sort of information why the platelets are dropping. So the possibilities are like this: a simple viral infection can give rise to low platelets, and the sepsis can give rise to low platelets, and the DIC also can give rise to low platelets. So I'd be very cautious about that. And even though now the dengue antigen, it was say that the dengue antigen was negative, but even I would prefer to specifically ask from the radiologist about this ultrasound scan. Ultrasound scan says it's normal, ultrasound scan abdomen, but I will double confirm with the radiologist whether there's no gallbladder edema or fluid around the gallbladder. That is to in a view of excluding dengue. And the second thing is to ask about the bilateral basal pleural effusions, because mycoplasma is well known to cause pleural effusions in pregnancy. So sometimes these things won't show in the chest X-ray. Initial stages, you won't get anything. The X-ray seems to be normal. But ultrasonically, we can get those two. And because the respiratory infections, I have to make sure the patient is having either influenza or the mycoplasma. And apart from that, all the other influenza, mycoplasma, and the procalcitonin, these things are sent. And also the echo was done, because any respiratory infection, even the influenza or the mycoplasma, can give rise to myocarditis. So the ejection fraction is normal. And again, when someone is having a sepsis with low saturation, we need to rule out the pulmonary embolism. So the venous duplex was done, it was normal, but I would think of doing the troponin and the D-dimers as a baseline for this patient. And other than that, so other basic investigations like I would prefer to repeat the blood cultures as well as the urine cultures, because the UTI and the blood cultures may be negative, because from the very beginning we have given the antibiotics as well. So I would prefer to repeat the blood cultures and the urine cultures on this patient as well. And finally, this is very important to go for the reassessing the patient again, whether the patient's clinically, whether we are having any evidence of deteriorating of the lung function, the chest or the abdomen. Yes.
Okay, sir. Thank you, sir, for your valuable input. Sir, I have another doubt. If the patient have the blood culture and the urine culture is negative,
Yes.
still the blood beyond this culture, the blood picture give a valuable information, sir. Blood picture,
Yes.
this infection.
Yes, of course. The blood picture will give valuable information, because sometimes when someone is on antibiotics, because usually the practice is after the section, we are starting with antibiotics anyway, right? So then the repeating antibiotics will give, the repeating blood cultures will definitely give a clue. Sometimes the first blood culture may be negative, but the second may be positive. So it's important to repeat it.
Okay, sir. Thank you, sir.
Thank you.
And okay. So, okay, again, sir have mentioned for my questions. So, antibiotic management wise, it was changed from we have initially give the cefuroxime, now it was converted to IV ceftriaxone 1 gram BD started. Metronidazole was continued the same dose in IV form, and clindamycin 300 milligram 6 hourly, and Tamiflu 75 milligram BD, azithromycin 500 milligram daily. It was started now. So, Mahen sir, again, what do you think about this antibiotic at the moment, sir? Is it adequate cover for the possible organism? And this change would is it necessary? Mahen sir?
Yes,
Hello.
thank you very much. Right. Okay. So now when you see 4 antibiotics in the antibiotic list, that itself says that we are not focusing on the problem.
Yes.
Right? So ceftriaxone, metronidazole, clindamycin, Tamiflu, and azithromycin. So now
Yes.
this 2026 surviving sepsis campaign guidelines, so they effectively say if you are targeting for a lung focus, there's no need to cover with anti-anaerobic agent. So therefore, I don't think now if you are excluding intra-abdominal pathology, metronidazole is not needed here. Another thing is, again, the ceftriaxone dose. Ceftriaxone dose, it's okay. It will cover most of the lung pathogens. But the issue here is ceftriaxone is given as 1 gram 12-hourly dose. So actually,
Yes.
if you are targeting for a lung and extra CNS infection with ceftriaxone, 2 grams daily would be the dose. So here I have reservation on ceftriaxone dose. So ceftriaxone is okay, but 2 grams daily would be okay. So then I'm not happy with metronidazole. Again, clindamycin. Clindamycin, if we are not suspecting surgical site or if we are not suspecting any sort of intra-abdominal, again, it would be not necessary to give. Azithromycin, I'll be okay because the physician thinks of pneumonia and atypical agents. So in this patient, it would be better if we can focus only on IV ceftriaxone and azithromycin if we are thinking of a lung focus, probable lung focus. So at the moment, still, I would say there is no need to go for meropenem, but still can manage with ceftriaxone and azithromycin alone. Are you okay,
Okay.
Alex?
Yes, sir. Yes, sir. Thank you, sir. So again, question to Chintaka sir. Now, according to the patient parameters, now she was on Muse 5 score. That means he had the moderate risk. So, what can we do in this stage? We should do need hourly monitoring. So, better HDU, ICU care, and the need the consultant obstetrician and anesthetic involvement. Is this right, sir? That because most of the time we don't have ICU availability to care the patient. Same time, we don't have the HDU facilities also in the ward. So at this point, practically, what do you think, sir? What we can do this stage? Chintaka, sir? Hello, sir?
Sorry, I was muted. So practically also, I don't think at this point she need ICU care as such because we don't have to give any cardiovascular support. Her blood pressure is maintaining, although she's tachycardic, and we can do the fluid management in the ward setup, and she does not need any mechanical ventilation or renal dialysis or anything like that. So uh, we may be able to manage in the HDU or ward setup if the ICU is not there. HDU would be the better place because she need hourly observations at this point. But if we don't have HDU facilities, it's very important for us to have a team, uh, guided team in the ward itself to give like a one-to-one care. We have acute site beds in all our obstetrics and gynecology ward, even in other wards. So it's very important to get the observations. Especially, I want to highlight the urine output. So that is something we most of the time we might neglect that observation, although we check the heart rate, blood pressure, and the saturation and the respiratory rate. So hourly urine output at this point is important. So whenever possible, we should get the ward staff to get the urometer. If it is not available in the ward from the ICU, attach it, and until we get a facility from the HDU or the ICU to manage the patient uh, in the ward setup. So doing the close observation, we can do like that. And when we are discussing or in getting involved in the obstetrician, also important not to just to over the phone manage the patient, but to get them to assess, consultant to come and assess the patient properly. To, at this point, we are trying to localize this infection. We don't know whether this is respiratory tract infection, we don't know whether this is intra-abdominal sepsis, or we don't know whether this is endometritis. So, doing a proper, high quality, good ultrasound scan, uh, if possible, with the transvaginal ultrasound scan to assess whether there are any collections inside the uterus. I know this is a cesarean section, so unlikely this is to have any retained products like placental parts. However, if the cesarean after the cesarean section, if the cavity was not sobbed properly, then there can be placental parts remaining inside, maybe missing cotyledons. So we have to keep that in mind and assess with the ultrasound scan if there are any suspicion, or if we suspect any pelvic collection, then we might have to go for CT scan. So that those kind of decisions we need to get the obstetrician's input. And also at this point, although we don't want to put the patient to the ICU, we need to get the critical care team involved in the patient management, even the patient is in the ward. So that would give more input for patient management. So that is how I would manage. And also one thing I need to maybe Dr. Samita also can comment on this about the fluid resuscitation. There in pregnant patient, although we consider once we diagnose sepsis is about 30 milliliters per kg in the first 3 hours, we might go for a little of a lower fluid load than a non-pregnant patient. So at MEOS 5, I would even I don't have the HDO, the ICU facilities, I would think of possible escalation later on, maybe within the next few hours, and get the critical care team involved.
Okay, sir. Thank you, sir. So next day, the post of day 3 at ward. Likewise, sir said the patient was managed at ward in an acute setup. So in the post of day 3, the patient again getting worse. The looks not well, and fever spike was 38.6 degrees Celsius, and the cough, respiratory rate 25, and bilateral basal crepitations are there, and saturation still 92 to 94. Yeah, the heart rate is 120 beat per minute, and blood pressure is now marginal, 96 to 65. Initially, it was systolic blood pressure was 110, but the capillary refilling time is less than 2 seconds. Urine output was reduced, but the adequate for weight, but it compared to before, it was reduced. The abdomen was mild to moderate tenderness that was there previously also at the lower abdominal region, and no bleeding or no vaginal discharge. Again, the repeated investigation shows that the WBC 24 high, CRP again 284, hemoglobin 9, it was dropped from 10 to 10, and the platelet 110, so it also reduced. And the serum electrolyte normal, serum creatinine again goes up from 54 to 90, and the procalcitonin 3.4. As here, what we have missed that the blood picture, as Samita sir was said, because everyone think about the sepsis, but we don't think about DIC stuff. It may be the common in during the post-op period. So the blood picture was not done. So the hemoglobin and platelet also reduced. And it may be indicated by the several other causes that have Samita sir has mentioned already. So now investigation clearly mentioned the sepsis part still going on, and it was not responding to the antibiotic change. And the UFR again, the field full of pus cells repeated, blood culture, urine culture was repeated, and HBS Staphylococcus aureus positive, Mycoplasma antibody negative, but influenza antigen positive. So here we have already started the Tamiflu with the clinical suspicion and the azithromycin for the atypical pneumonia. So we don't have any escalation on this management because the Tamiflu 4 started at this point. So now again, question to Mahen sir. How is this condition now? Is it sepsis, sir? Because the patient have that organ dysfunction now. The hemoglobin and platelet is dropping, and the renal function is worsening, and the still sepsis part is there, and infection fever is there. So what do you think about at this moment, sir? Mahen sir?
It's definitely it is definite sepsis. So now sepsis according to the latest guidelines can be classified into definite sepsis, probable sepsis, possible sepsis, and no sepsis. So now we have been going through the trajectory. Initially, first 2 days, it would be possible sepsis or probable sepsis. Now on the day 3, I think, no, it is day 3 or day 4.
Yes, day 3.
The patient and we are in the verge of trying to escalate the care to HDU and ICU. So now with this clinical setup and the investigation findings, it is definitively, you can call it sepsis. But what we have to find here is the focus, the probable focus. Now we are thinking of lung focus, probable pneumonic focus. And the second one is possible intra-abdominal because of the possibility of surgical site and other issues. So, and we have to have some sort of a multidisciplinary discussion and try to focus on the main organ involved. Now, again, if you want to have a useful information from full blood count, there's something called neutrophil to lymphocyte ratio. So which is broadened in sepsis, and it gives information as sensitive information as in procalcitonin. So you can have that as well, neutrophil to lymphocyte ratio. This is definitive sepsis.
So instead of procalcitonin, we can check that. No, sir. The neutrophil lymphocyte ratio.
That's right. So if you don't have the access to procalcitonin, most of places you don't have, you can use this NLR ratio or drop in lymphocyte rate. So that itself shows indicative of immune dysfunction. So that you can use as a surrogate for procalcitonin levels.
Okay, sir. So in our mind, now the possible diagnosis, as I mentioned, the respiratory tract infection, lower endometrial collection, that means the infected endometrial collection, and this is the emergency section. So most of the time we are seeing the surgical site infection after the emergency section. So that would be that could be a possible differential diagnosis. And as Banaklasa already mentioned, that timing of transfer, it should be transferred to ICU because now the sepsis part is worsened. So it's now the new score is more than 5, I think. So we have to transfer the patient to the ICU as soon as possible. So management-wise, that happened. The obstetric team consult with the anesthetist and they have transferred the patient to ICU. And the ceftriaxone and metronidazole was omitted, and the meropenem 1 gram TDS was started. And teicoplanin 400 milligram 12-hourly, 3 doses, and daily was given. Again, Mahen sir, what do you think about this antibiotic change, sir? Now we have, this is almost day 3, finishing up 72 hours. We have changed cefuroxime to ceftriaxone. Now we are going to the meropenem. And also teicoplanin. What is the importance of this antibiotic change and the teicoplanin, sir? Is it necessary at this moment?
So now, yes. So now we are planning to have a salvage option. So the only salvage option that we have is meropenem. So I don't have any reservation in starting meropenem 1 gram 8-hourly till you get microbiological inputs and other inflammatory markers. But when you consider adding teicoplanin, so the whole idea of adding teicoplanin is to provide a wider coverage. So what is the extra coverage that you are planning to get with teicoplanin, which does not cover with meropenem? So that is only MRSA. So now when you analyze the MRSA prevalence, what we can see is MRSA is more common in patients who are having renal transplant, renal replacement, and who are having the long lines for long time. So therefore, adding meropenem is okay for me, but starting teicoplanin is still, I would say, premature, and therefore meropenem alone would be enough to cover this patient. And because of the fact that patient had direct antigen test positive for flu, no, it's not.
Yes.
Yeah, and
Thanks.
the respiratory features could be due to flu alone. And
Yes.
you can give meropenem, keep azithromycin, and can give 3 to 5 days of Tamiflu, because flu is disastrous in pregnant women. So therefore, those three would be enough:
Oh,
azithromycin, meropenem, and
and
Tamiflu.
I think we have continued those drugs. We have omitted the ceftriaxone, metronidazole, and only we have continued those three drugs. And other things, the patient renal function is now deteriorating. Sir. Now it was 50 to 94. According to the KDIGO guideline, patient is having the AKI. So whether the meropenem dose we need to reduce, or what about teicoplanin? Teicoplanin also, sir, in the AKI time, we are not starting as early as possible. No, sir.
Yeah. So now there's two things. One thing, so you have to look at the kidney. And the second
Yes.
one, you have to look at the patient's life. So if you were to choose from either one, with the renal damage or the patient's life, so you have to select the patient's life. So if you think that any dose reduction will have a negative effect on the outcome, so you can keep the drugs, right? So you can always come back later and consider about kidney late. So generally in septic patients, there's something called augmented renal clearance. So therefore, sometimes even if the serum creatinine goes up, still you can give normal doses, or sometimes you might have to give a higher dose because of the fact that patient might have augmented renal clearance. But so again, nephrologist opinion would be invaluable in this scenario.
Yes, sir. Thank you, sir. So then the next day at ICU, patient alert and conscious. The fever is 38.4 degrees Celsius. Occasional cough is there, dry. Bilateral lung, occasional creep. Now the respiratory rate is reduced. Initially it was 24, now 20. And the saturation is 96 to 98 on air. So respiratory wise, she shows some improvement. But she had tachycardia, 120 beat per minute. Now the volume of pulse is low, BP dropped 80 to 40, and capillary refilling time more than 3 seconds, and the urine output was reduced. The abdomen soft, again mild moderate tenderness is there, patient not showing significant tenderness, and no bleeding or discharge. So in the ICU, we have done the ABG as the patient have the respiratory and now the hemodynamic involvement. The pH shows 7.21 is acidosis, and the PCO2 28.2, it could be the compensation, and bicarbonate 18, so we show the metabolic acidosis, base excess minus 8.6, lactate 3.2. So it shows the metabolic acidosis with the respiratory compensation. So the question to the Iresha madam, what would be the reason for this finding, madam? Because patient was stable up to day 4, and at ICU she was developed hemodynamic instability now, and ABG also shows fluid inadequacy. What do you think, madam?
Thank you, Alex.
Yes,
So,
madam.
considering the history and her current hemodynamic status, she is hypotensive and tachycardic. with the capillary refilling time of more than 2 seconds indicates that he's hypovolemic, which means her organ perfusion is compromised at this point. And could we lead to in sepsis, when we consider the pathophysiology, there's a fluid leak out of the capillaries, and the fluid that we give is inadequate up to now, considering this history. Because of this hypovolemia, her lactate has gone up, and the blood gas shows metabolic acidosis with compensatory respiratory hypocarbia. So at this point, I would say that we need to do aggressive fluid resuscitation, plus if it is not responding to fluid resuscitation, we should consider adding a vasopressor like noradrenaline at this point. The current recommendation says if a patient is severely hypotensive, even at the beginning, you can start with the fluid resuscitation plus adding the vasopressor noradrenaline together. So when we give fluid resuscitation, that we should give 30 ml per kg fluid boluses up to 3 hours during 3-hour period. And if we require a large volume for resuscitation, we can consider albumin at this point. But it is not recommended to give any starches or the gelatin solutions for these kind of patients.
Thank you, madam. So the actual management, what was done, we have inserted the artery line was inserted because peripheral pulse was low weak to identify by the even saturation drop. So we have put the arterial line and to monitor the continuous blood pressure. And we have given the bolus almost 1.5 liter of crystalloid, normal saline, and the RL alternatively, ring lactate alternatively, with a frequent IVC assessment. And the IV fluid, again, we can start 100 ml per hour. And with that, to maintain that the blood pressure, systolic blood pressure more than 90 or the MAP more than 65, we have started the noradrenaline 0.3 mic per kg per minute. So I want to ask Resha madam, what about this fluid management, madam? Is it an adequate volume or we can go further than 1.5 liter?
1.5 liter, considering if it is a 50 kg woman, that's a 30 ml per kg dose over 3. You can give it over 3 hours. That's an adequate volume at the moment. And then the following that, we can maintain this amount with the crystalloid.
Crystalloid, 100 ml per hour.
Yeah. And that's, I think that's enough. Then we have to consider still whether the other hemodynamic parameters are okay at this point. With if it is not improving, then we can start on NORAD or as a second one, vasopressin. If we require, yeah.
And again, question to Mahen sir. What about steroid in this patient, sir? Whether the steroid, is it recommended? Because theoretically it shows some advantage that not only for the adrenal suppression because of the sepsis-induced sympathetic surge, but also it has some improvement in endothelial glycocalyx function and improve the vascular integrity that affected in the sepsis part, septic shock. So what do you think about the steroids, sir? Whether we can start in this patient?
Yeah, thank you. So actually now that question should go to anesthetist or intensivist, right? But theoretically, all the information that you have said, because its ability to stabilize endothelium and its ability to sensitize certain cells, it seems to have a theoretical usefulness. But the adult surviving sepsis campaign guidelines, so adds giving steroids under ancillary recommendations. So it is, I think, as far as my knowledge, it is not a strong recommendation. And if that recommendation is there, it has to be weak recommendation with a lower level of evidence. But I think anesthetist or intensivist or a physician would be able to give you a better answer than myself. But if you need steroids for pathogenesis of this to overcome whatever the other pathologies, of course, you can give steroids under antibiotic coverage if it is necessary. But I don't know how effective steroids for sepsis. So that has to be discussed by physician, intensivist, or the anesthetist.
Then we direct the question to the madam, Resha madam. Then what do you think about steroid, madam? Are we practicing routinely, madam?
Actually, the previous recommendation was that if your inotropic, the vasopressor requirement is going up, then to add steroid, the hydrocortisone or whatever, 50 milligrams 6 hourly.
6 hours.
Yeah. And the current recommendation
I think the recent yes, madam.
the 26th guideline, but again, it is not a strong recommendation.
Strong
Like
recommendation.
a conditional, what they say, a conditional recommendation says that you can add hydrocodone, whatever steroid, but it's not a strong recommendation.
Thank you, madam.
Alex, can I
Yes,
also
sir.
comment on that?
Yes, sir. Yes, sir.
So actually, there was I'm just about the evidence what we have with the steroids and the sepsis. So in one of our obstetric sepsis articles recently came in 2000, close to 20s, they have mentioned there are RCTs showing that there is only about very minimal 2% reduction in 1 month mortality, ICU related mortality when you give steroid for sepsis patient. But again, that is not for the obstetric septic patients, and the quality of the studies were poor. So none of the guidelines strongly support. Some guidelines advise not to give steroid in cases of sepsis. Even our RCOG guideline do not consider mention as do not consider steroid for sepsis, but if the patient need to be delivered early, then for fetal maturity, use steroids cautiously for the fetal lung maturity. That is what the RCOG sepsis guidelines in pregnancy recommendation is there. So it's not widely practiced apart from this fetal maturity.
Okay, sir. Thank you, sir, for valuable input. So, again, in the ICU, to check the adequacy of the fluid resuscitation, we have done the ABG. It was repeated. It shows that the pH is 7.32, it was improved, and the bicarbonate is 21, again improved, base excess minus 4.2, and the PCO2 30, lactate 2.1. So it clearly shows that the fluid resuscitation shows some improvement in this hemodynamic system. And the urine output, but still low, 10 cc per hour, even after the fluid boluses. So at this stage, we have done IVC assessment frequently, and it shows the collapsibility of the IVCT is less than 40%. That means patient have some adequate fluid in the vascular system. And the lungs ultrasound shows some B lines. It's difficult to visualize as the patient fat tissue and the breast tissue will obscure the ultrasound waves. And the furosemide 20 milligram was given because we suspicious of the B line, maybe cause over because you already given 1.5 liter. So maybe the fluid overload also we have that was come into our mind. And the maintenance 100 cc per hour was continued. After the furosemide 20 milligram, the urine output start to improve. So again, I want to ask the question to Irisha madam and the Samita sir. So what do you think about this fluid management again? Whether is it really overloaded? And in this stage, furosemide is necessary because the recent evidence shows that in the acute kidney injury, we not giving the furosemide because sometimes it may cause renal toxic. So what do you think, sir? Is this management is right, or whether we can go for the further more valuable management?
So regarding the fluid management, we have to look for all the parameters, whether the patient is having adequate urine output is one, and the creatinine levels, whether it's getting better is the second one. And it's always better if we can reduce all the nephrotoxic drugs. Sometimes unnecessarily we are giving painkillers and so on. We also have a impact on the kidney function. So giving fluids and keeping the blood pressure, now this most of the time we should be very careful about the pre-renal failure. Now we have to correct the pre-renal failure to protect the kidney function. So depending on the, now we did this in this regard in this patient, we did the cardiac assessment and the ejection fraction was normal. And also the IVC is a collapsible. So we are still having a bit of a room. If the output is not adequate and the creatinine rising, we can give the fluids more. But if we can maintain the adequate amount of fluids and the output is maintaining, I don't think the patient needs any furosemide, but it's always is better to continue with the fluids.
Okay, sir. So in case if that we adequately replace the fluid, suppose the IVC is the good volume and no lung issues, but the urine output is not improving. This is the similar scenarios we have encountered most of the time with the sepsis. So at this stage, whether we can give furosemide. Sometimes we are practicing that furosemide bolus 40, even 40 milligram bolus. Then following that, we are starting the infusion. Is it recommended, sir?
So it is recommended in the sense like it's a collective decision, like because now if the patient is not responding for the fluid resuscitation and the creatinine and the output is reducing, that means there may be a part of the intrarenal pathology. Right?
Okay.
Sometimes these things, the acute tibial necrosis is highly likely in this situation. And also, if the patient is having AT and causing the reduced urine output, then we have to monitor the other parameters, whether the electrolytes, the creatinine, and also if there's a rising, sometimes we are seeing the patients, despite everything, the creatinine is rising. So then until the tubules are recovering, we have to give adequate support. Sometimes patient might need a dialysis as well. But furosemide, we are giving like, say somebody is having a reduced urine output due to heart failure,
Yes, sir.
right?
Yes.
So that type of situation, you have to balance it. Otherwise, I don't think there's a real indication for give furosemide at this point, just to in a view of improving the urine output.
Urine output, yes.
Right, so we have to look for why the patients after adequate resuscitation also, if the urine output is not picking up, then we have to look for the reason behind it, why it's not picking up, rather than because this is something like giving Panadol for headache, like kind of a thing.
Yes. Yes,
Right,
yes.
so we have to dig and see whether there's any offending drugs that we are giving and anything else, and also we have to keep the eye on the renal functions, why the patient is having this output is dropping. If there's a real indication, I don't mind giving furosemide infusion, but it's always we have to look for the reason behind it, why it's not picking up.
Okay, sir.
Can I add a little bit to this?
Yes, madam.
Yeah. The 26 surviving sepsis guideline, there's a recommendation. It's not a strong recommendation. It's a conditional recommendation where it says after active resuscitation phase, if the signs of fluid overload is there, like edema, even after coming down the vasopressor requirement, that when patient is hemodynamically improving, and when if patient is edematous and the other signs of fluid overload is there, it recommend to take fluid actively out with the diuretics, or if at all, if necessary, to go for hemofiltration or hemodialysis if not responding. But it's not a strong recommendation, but it says actively remove the fluid. That's not in the acute phase. It's like after initial, not in the initial phase of resuscitation.
Okay, madam. Thank you, madam. So, how we actually proceed in ICU? Then we have done the fluid resuscitation. After that, the noradrenal requirement was came down. So we have tried to came down tail off to 0.05 micro-kg per minute. So that's mean patient obvious fluid depleted. And the blood investigation was taken. Full blood count, serum electrolyte, renal function, liver function, coagulation profile, CRP, and the procalcitonin also we have sent. And the antibiotic, the meropenem, Tamiflu, azithromycin, clindamycin, teicoplanin was continued. So again, Chintaka sir and Samita sir, what about the possible source of this infection? Because now at the moment we have the lower respiratory tract infection, intra-abdominal infection, endometrial collection. So we have the possible DDs now. So what we can do to identify this possible cause? Because without identifying the source, it's become difficult to treat the sepsis, even though that is reduce or the symptoms are respond to the antibiotic. Anytime it can come out again. So what do you think about, sir? Chintaka sir?
Yeah, okay, Alex. Yes. So lower respiratory tract infection because she was having cough and fever for a lot during the course of the infection. However, now I think we have done the X-rays before,
Yes, improve
and
that.
the lung signs were not 100% like very suggestive of a lower respiratory tract. And also, what my understanding is, if the antibiotic can reach a site of infection, then we would see a rapid response from the antibiotic. But this patient is running high temperatures for almost 4 5 days, and
Yes.
in my first opinion, do we are we delaying the finding the source of infection is the main thing, rather than actually the differential diagnosis, this finding the source of infection. Actually, even at this point we may be having a little bit of delay, about 48 hours.
Yes.
We need to have assessment, abdominal examination, and ultrasound scan of the abdomen with the help of a transvaginal scan. If the uterus is not very well involuted, and if the uterus is tender, then it suggests it's most likely a intra-abdominal the uterine cause like myoendometritis or endometritis. And all of this time, it was documented there is no obvious offensive vaginal discharge.
Yes.
But in sometimes in the ICU setup, whether the obstetric team is attending and uh, examining patient with speculum examination and all, I doubt. So we can do the ultrasound scan to do that. Other things also we need to think, like surgical complication during the cesarean section, emergency cesarean section, whether there was any bladder injury or any possible bowel injury can lead to any other collections outside the uterus. So those are best seen with the CT scan. So If the patient is running temperature like this, singing pyrexia, we always prefer a contrast CT after discussing with the radiologist. So, my opinion is this is more towards, and the patient is always complaining of abdominal pain, and the uterus gradually became tender on your notes. So, more than the respiratory tract infection, more towards a kind of a pelvic infection. Uh, if the organ injuries are relatively rare to cause pelvic collections, so first would be any infected endometrial material, then the collection.
Okay, sir. So I think sir suggesting to go for the CECT abdomen to find out the source. No,
Yes,
sir?
ultrasound followed by the CCT abdomen.
CECT. Okay, sir.
If the
So
ultrasound obviously finds something, a collection, we might not even need CT.
CET. So we can go with that finding.
Yes.
Okay, sir. So on the day 5, again patient alert and conscious. Now the fever spikes little bit reduced, 37.8, and little bit mean almost near normal. And shortness of breath, no shortness of breath. Now the lungs are clear. Saturation she maintaining 98%, and on air. And tachycardia was improved, now 101, and adequate. She had the pulse, adequate volume. Blood pressure is with the 0.03 mic per kg per minute. She is maintaining, and the capillary refilling time less than 2 seconds. So urine output is now adequate, but still she has, even though day 5, she has a mild to moderate tenderness at the lower abdomen. But it was reduced compared to day 3, because in day 3 it was higher compared to day 5, but still no bleeding and discharge. So investigation again shows that the inflammatory and infective parameters are improving side. That WBC, it's come from 22 to 18, and the procalcitonin 3.4 to 2.7, and the CRP 240 to 184, and electrolytes normal. And again the serum creatinine also from 91 to 75. Liver function marginally elevated, not significant, but coagulation screening and INR was normal. So repeated the blood culture shows no growth, and urine culture again no growth. As sir mentioned, we have done the ultrasound abdomen. In that, they have mentioned there's a minimal ascites, could be post-surgical, and 1.5 centimeter thick focal fluid collection in the superior surface of the uterus. An echogenic area with the uterine cavity, quarry, it could be blood clot or infected protein product. Then, according to the surgical team and the multidisciplinary team opinion, we have go for the CECT, chest, abdomen, pelvis, to rule out everything. That revealed involuting bulky uterus with 3.5 to 4.2 centimeter low density area within the uterine cavity, which could be represent some fluid and blood clot, and 1.5 centimeter fluid collection seen anterior superior to the uterus with minimum ascites. So again, Chintaka sir, what do you think about this finding, sir? What is the next step of management as patient is now clinically showing some improvement? So shall we wait for any intervention, or shall we go for the urgent intervention? What do you think, sir?
Should
Chintaka
I?
sir?
Yeah.
Yes, sir.
Yeah. So if we go back to the, if you can move to the previous slide with the CT.
Yes, sir.
Yeah. So maybe this focal collection seen anterior to the uterus, maybe at the incision site, there it can be edema
Yes.
as well as some bleeding at the surgical site. But this collection intrauterine 3.5 to 4.2 centimeters is a relatively large collection. And blood, even if it is just blood will act as a very good culture medium for the organisms. And so she had risk factors for endometritis because she presented with dribbling. There was meconium. So there can be intrauterine infection even in during labor. So this infection might have persisted and got the uh, infection, and also it is remaining inside blood clot. So personally, although there is partial response uh, from the antibiotic, as we know, this antibiotic penetration for these kind of collections is very poor. Uh, Source control is best achieved by drainage or removal of the infected material, and given the collection is bit large. If it is a smaller one, we might think, okay, continuation of the antibiotics, but for me, it's a bit of a large collection. However, when doing evacuation for this patient, it is also a bit of a tricky situation where the perforation risk is higher, because endometritis and postpartum mother perforation is anyway high. So it need to be done by an obstetrician with good experience under ultrasound guidance. So my personal opinion is, although patient is partially responding and this patient went into sepsis and also low blood pressure with organ dysfunction, we should not allow the patient to go in this cascade for a long time. So removal will enhance the treatment as well as the recovery.
What do you think about Mahen sir? Mahen sir, whether sometimes
Yeah.
treating the antibiotic with some amount of intraperitoneal, it's not a huge, right? In my appointments, I have seen that there is some emergency section. After that, there is a intra-abdominal collection. Without intervention, we have managed the patient with antibiotic with the multidisciplinary involvement. So, what do you think, sir?
Yeah, so that is also a possibility now with antibiotics. It can, with the autolysis and body spontaneous recovery mode, it can resolve. So now Dr. Chintaka has made a very important point. So that is the source control. So if you are thinking of a possible source, it need to be evacuated. It need to be removed. But the timing, the issue is with timing. So I 100% agree with him. If you are thinking a possible source, it need to be removed. But when are we going to do that? So now there are instances when you are arranging for source control, so you have to arrange it immediately. So whether the patient is septic or septic shock, for example, if the source is from biliary tract or intra-abdominal, involving intestine or perforation. So that has to be done then and there, even if the patient is septic. So there are some other conditions where you have to time source control, and your timing has to be when the patient is stable. So you are not going to go inside and do some intervention in an unstable patient. So now that timing has to be decided with the concurrence from all parties involved in this multidisciplinary discussion. So now, yes, patient is slightly improving. If the surgeon or the VOG says that we have to go and do the source control now, yes, of course, you can go ahead. But it has to be decided with the concurrence of everybody, adjusting all odds. So if there's a risk of damage, organ damage, as Chintaka said, so we can wait till the patient stabilize, and then you can go ahead and do the source control. Sometimes a minor collection or minor things may resolve on its own. But if the surgeon says, yes, definitely you have to go and do the source control, but the timing has to be decided whether the patient, once the patient becomes stable, or if it is sepsis. So sometimes you might have to go and remove the source.
Yes, sir. Thank you, sir. So as a management, what we have done, so the ERCP was done. So I think the next question was already answered by the sir. So is the correct decision? Yes, it's a correct decision that we have to do the source control as early as possible. in 2026, even the sepsis 6 guideline, they have mentioned that the within 1 hour source control is much better and it has a good outcome compared to late source control. So after the source control, we have done the we have done the ERPC. As the pre-operative wise, we don't have that much of challenge because patient was hemodynamically stable. So we have done the fasting and we have go for the normal routine induction, and we have done the ERPC without any problem during the surgery. And on post-op day 6, patient shows very improvement. The patient alert, conscious, no fever, no shortness of breath, and the heart rate was improved. Volume status is good, and no red we have fully tailed off. Urine output adequate. Now the abdomen also shows soft and no bleeding. And she opened the bowel after 6 days, and no pain on mobilization. We have started to mobilize the patient. And repeated investigation shows the WBC 10, hemoglobin platelet normal and improved, INR normal, electrolytes, serum creatinine was normal, and the CRP also come down to 95. So on day 7, the patient was clinically improved and inflammatory infection markers was reduced, and standard ICU care was given throughout the period, and the continuation of antibiotic was done with a discussion with the micro team, and we have sent the patient to ward on day 7. And from day 9, she was discharged with the re-escalation or reassessment after the in the ward period. So here the key learning point through this discussion, what we have find out, the maternal sepsis may initially appear subtle because some physiological changes of pregnancy can be mimicked with the sepsis that lead to delay in identification of the sepsis. So in this case, we have to go for the assessment and Meo's chart to find out early trigger. And persistent tachycardia warrants urgent reassessment. So if the patient have the persistent tachycardia after fleet assessment, so we have to be very cautious. And MEOS facilitate early escalation. So in our setup, we are using the MEOS. Sometimes we are not considered as an important tool. So that makes the mistakes and deterioration of the patient, even after the PPH. So MEOS chart should be implemented each and every ward during the acute post-surgical patient. And the septic shock can develop despite initial preserved blood pressure because these hormonal changes make the blood pressure was low, so compared to normal people. So the drop of blood pressure can be not visible at early stage. So we have to be very cautious in the, even though the preserved blood pressure patient can be have a septic shock. And the source control is essential in sepsis, as is recommended. It should be done within 1 hour and early as possible. And dynamic assessment guide the fleet management. So we have to go for the macrovascular parameters to give the fleet. And it's better we not overload the patient, that will lead to further problem. And multidisciplinary management improve the outcome. So almost always we have to have the multidisciplinary input to bring a good outcome of the patient in the peripartum sepsis. So that is the end of my case presentation and the discussion. I think we have done most of the practical dilemmas we have cleared out through this presentation and the discussion. I again thank you for the panel consultant, Dr. Chintaka Banagala sir, the consultant obstetrician and gynecologist at DMH, and Dr. Samitha sir, at consultant physician at Castle Street Hospital, Mahen sir at consultant microbiologist at NHSL, and Iresha madam, the consultant anesthetist at Castle Street Hospital. So from audience, if you have any doubts, I think you can ask from the panel now.
Alex,
Yes, madam.
there are questions in the chat box.
So So there's one question. In pregnancy with development of placenta, the third blood pressure will be low. Can we take systolic blood pressure less than 90? I couldn't understand that.
I think they are talking about the SOFA score, maybe.
So fast score.
Yeah.
What do you think about, sir?
So there are modified SOFA scores for the pregnancy for the same reason, because there will be increase in the respiratory rate and the blood pressure will be low. So actually there are uh, adjusted in the presentation. We saw that there are modified ones. Respiratory rate in the Q SOFA, respiratory rate is taken as more than 25, not 22, and the blood pressure will be taken as less than 90 rather than 100.
Yeah.
So there are adjustments for that.
I think we have to go for the holistic approach in this patient. Yes, sir. So the Q SOFA is not recommended in the 2026 guideline
Yes.
because it misleads most of the cases. So I think we have to go with that screening tool to identify the sepsis. Second question, is it okay to give the steroid for the fetal lung maturity in presence of systemic infection?
I
What do you
think we
think?
have already
We have
answered
already
that.
discussed this question, sir.
Yeah. We can give
And
the question.
yes, so there is a place for the sodium bicarbonate in a patient with moderate metabolic acidosis with low bicarb despite the fluid resuscitation. What do you think about this, madam? Resha, madam? Dr. Gunawardana has asked, is it the place for the bicarbonate in moderate metabolic acidosis with a low bicarbonate, even though after the fluid resuscitation? What do you think, madam? Madam?
Um, Thank you, Alex. So
Yes.
usually what we should do after initial fluid resuscitation, we should do a repeat blood gas and see the lactate levels. And bicarbonate itself is not an indication the low bicarbonate itself is not an indication to give bicarbonate. If the pH is less than 7.1, persistently, if it is less than 7.1, is the only indication. That's again because when you are giving the vasopressors and inotropes, the action won't affect if there's persistent acidosis. That's the only indication. Otherwise, there's no indication to give bicarbonate in the presence of low bicarbonate in the blood gas. It's the fluid
Oh,
resuscitation,
yes.
adequate fluid resuscitation, and if you require a large volume of crystalloid, then you can go for albumin. Yeah,
Right.
you can't give a large volume of crystalloid, so then you have to consider albumin, but not the gelatin or the starches.
Okay. And Dr. Hemant Pereira asked that dribbling for how long was a sample of liquor or high vaginal swab done at the point of diagnosis dribbling? Was sample of liquor taken at the time of LSES? Were the three cultures done after she was given antibiotic at the LSES? What do you think about, sir? Banagla, sir? The Pereira, Mr. Sir, are you there?
Hemant Pereira, sir, I don't know whether he's here. I hope everyone no need of introduction of Hemant Pereira, sir. He's a very senior obstetrician. He wanted to probably clarify the case.
Yes.
Dribbling for how long? Actually, it was not there in the case discussion. So maybe he wanted to make a point that at, with the high vaginous swab, it's important to take at the time of the dribbling, and also maybe if you are suspecting endometritis at the time of the cesarean section, it is important to take samples of lico for the culture at the time of the cesarean section. And he want to clarify whether the cultures done after the prophylaxis antibiotic given at the LACS. That of course probably yes, uh, because cultures anyway for a cesarean section we would give prophylactic antibiotics.
Okay, sir. And another question, so what are the indication to do the procalcitonin? I think it was explained by the consultant microbiologist. And is there any different in introp antibiotic and the antibiotic and dose in a normal patient and the dribbling patient or patient suspecting sepsis? I think Mahen sir.
Yeah. So
Yes, sir.
now dribbling itself is not an indication to give antibiotics, but if there is a prolonged dribbling, yes, you can give antibiotics. So that doesn't fall into the definition of prophylaxis antibiotics. So that becomes almost like a treatment. It's therapy or preemptive treatment. But the surgical prophylaxis is different. Surgical prophylaxis is antibiotic prophylaxis that you are giving to prevent surgical site infection. So now there's one question on surgical prophylaxis. So how many doses? It's single dose with the induction. And earlier it used to be given at the time of clamping the cord. But now it has to be given 30 minutes before, as you are doing for a normal routine surgical prophylaxis.
Okay,
Okay.
sir. So, okay, sir. That was explained. Okay. The progress on protection is okay. Is there any place to give prophylactic antibiotic for the normal vaginal delivery? Is there any place to give the prophylactic antibiotic for the normal vaginal delivery in a normal patient? That is the questions. Another question, sir.
Yeah. So normal vaginal delivery. Now, when you are giving prophylaxis, antibiotic prophylaxis, there are certain rules. It is just like a cricket match. So if you are playing cricket, so you have to play according to the rules. So now, normal vaginal delivery is not a condition where you need antibiotics. It is a natural process, no? So therefore,
Yes.
even without antibiotics, there won't be any harm. So only problem is if you are anticipating any sort of complication, any infection, endometritis, or any other thing, for that you can give antibiotics. So those are not prophylaxis; these are treatment. I think VOG can give a better answer for that.
Then it's directed to
Doctor?
Banagala, sir. Yes, sir.
Yeah, Dr. Banagala, yeah.
I would agree with Dr. Mahen's comment on this. So normal delivery, if it is uncomplicated, you don't need. But if if we are suspecting for infection in the next few days, examples, patient having offensive vaginal discharge or lico is warm and offensive, and if the patient already having intrapartum fever, or if the patient has had extensive vaginal tears, needing multiple suturing, or obstetric anal sphincter injuries following a normal vaginal delivery, those are the indications they need antibiotics. Otherwise, no need.
Okay, sir. To Mahen, sir, how to differentiate this initial CRP rise from post-op CRP rise? What do you think, sir? Yes.
Yes, now the post-op CRP rise, so it follows a typical pattern, right? So now if it is a major surgery, the post-op, it increases from day 1, day 2, and day 3, and it peaks at day 3 and day 4 and come down later, right? So that would be the normal rise in CRP in a patient who is undergoing a surgical event. But in this patient, what we have seen is within one day, within 24 hours, it had gone up from 24 to 254. So that is
Yes.
more than 10 milligram per hour CRP. So we call it critical CRP velocity. So that means there is something wrong in this patient. And this CRP velocity, if it exceeds 200 per day or 10 per hour, so that itself says there is some problem is going on, either sepsis or a condition which causing severe inflammation like pancreatic necrosis or extensive tissue damage or something like antiphospholipid syndrome flare up or something like that. So you have to be vigilant on that. So that is how this CRP velocity operates. So CRP velocity, depending on the rise, you can differentiate their risk levels. And literature says it is as equally sensitive to procalcitonin in differentiating sepsis or patients who are likely to develop sepsis, right? So you have to read on that there are two things, CRP velocity and estimated CRP velocity. Okay?
Okay, sir. And in influenza positive cases, is it safe to give steroid?
Yeah. Again, influenza.
Yes.
If you need, it depends on whether you really need steroids or not. So if the multidisciplinary team says, yes, we need to give steroids. So in that case, we can give steroids, keeping the patient under observation. If there's anything goes wrong, we can always escalate the care. But routinely, you don't need to give steroids unless something like COVID associated upper respiratory tract or lower respiratory tract or something, Miss C or Miss E, something like that. There's no routine requirement for steroids in flu.
Okay, sir. Okay, sir. And albumin indication in sepsis, that was, I think, explained by Resha Madam. The basal cryptid is okay to go with 30 ml per kg dose. So the patient have the respiratory tract infection. Meantime, is it okay to go for the 30 ml per kg dose? Resha Madam, can you give me an explanation for this, Madam?
It actually with this basal crepitation, you have to differentiate whether it's a cardiac
Yes.
or because of the infection. So if it is a cardiac, then you have to consider giving a lower volume because this indicates pulmonary edema. But if it is respiratory, of course, you can go with this volume for initial resuscitation. But as I said before, as we are giving large volume of crystalloid, which will go out of our circulation, which will come later on as edema, we can actively remove this fluid later on, not in the active phase. So we can use either diuretics if the renal functions are okay, or then if not, then you have to consider hemodialysis or CRRT, whatever the mode, if they are fluid overloaded.
Okay, madam. And how frequently should we monitor the lactate level in septic shock? What do you think, madam?
There's no, like, we can't say it's hourly or like that.
Yeah.
It all depend on the way that we give fluid resuscitation. Lactate level will indicate whether our fluid resuscitation is adequate or not. So if the lactate is improving, then it means the organ perfusion is getting better. That's an indication of whether our resuscitation is adequate or not.
Yes, I think each and every time to check our fluid resuscitation, we have to do that. And with the hemodynamic and the clinical parameters, I think we can decide to do the repeated lactate, no, madam?
Yeah. So yeah, after after giving fluid bolus, if the hemodynamic parameters are improving, then you know it's getting better, and then you can do blood gas to assess the lactate level.
Okay, madam. And if the patient is critically ill, like this kind of case, are we going to stop breastfeeding till recovery? I don't think is it necessary. What do you think, madam? Madam?
I don't know whether can we ask from Dr. Banagala or the Samita whether should we stop or not? So I don't think it is necessary from my point of view, unless there's like if the patient is on ventilator or like that. Otherwise, if a conscious rational patient, we can continue breastfeeding.
Mine, sir? What do you think about this, sir? Mine, sir?
Yeah. So now if you are breastfeeding, so that will allow the baby to thrive and to get the immunoglobulins and all. So only problem is something secreted in the breast. If it goes and cause harmful effect on the baby, like antibiotics or any other drugs. So that need to be discussed in relation to what the drugs that you are giving to the patient. But basically, some of the drugs that which are safe in breastfeeding, if it is given, so you can allow breastfeed as if the patient can. Otherwise, with the concurrence from the multidisciplinary team, so we have to take a decision whether to continue the breastfeeding or not. But per se, infection per se, or drugs excretion through milk, if
Yes,
it is
that
not
is the
harmful for the baby, you can go ahead.
go ahead with the breastfeeding. Yes. And again, Hemant Perera sir made a statement that with a fever, high WBC with neutrophilia, high CRP, and procalcitonin, following a mother who had a prom, despite the positive influenza test, bacterial infection is most likely, and the most common source is the uterus, and imaging was indicated much earlier. So that is the clear statement, sir, that was missed, I think. Management should be done early, source control. And Sri Lanka College of Gynecology's guideline on management of term pre-labor rupture of membranes, arterial line after initial assessment for confirmation, high vaginal swab is recommended for culture and antibiotic sensitive test and for the STI. Yes. And sir has give us a good statement that we have to follow, I think, in our future. Significant of two positive tests is in this patient. So I think the significance of two positive HPS test in this patient, yes, because I think the infected collection also there. Maybe what do you think about Banagala, sir? The Madhushani has a question that significant of positive two HPS tests in this patient. So what could be the reason, sir? It should be persistent infection, or it could be that infection can cause endometrial infection. What would be the reason for that?
As I can remember, so there were two isolates of organism detected. Is that maybe the thing that she's asking? First one detected GBS, and there was a
Second one is
Staphylococcus
Staphylococcus
aureus.
aureus.
Yes.
Nefarious, no?
Yes, sir.
That I think mine sir will but both can be the GBS is of course can be a commensal in the vaginal flora up to about 20% of patients, but it can cause ascending from vagina to the uterus can cause infection. So initial culture uh, why the other organism was not identified. Actually, I'm not very sure about that.
So, now we have to understand that vaginal swabs. So you can get any organism. You can get coliforms, you can get staphylococcus, you can get group B, and similar to that. But if you isolate a primary pathogen, so that would be significant. Primary pathogen means somebody like group A streptococcus, the one which causes puerperal sepsis. But when you give antibiotics and when the patient is in the hospital and subjected to recurrent PVs and that sort of thing, this environment can be colonized by different organisms. So when you do swabbing, so you can get any of these things. So what the issue is, how to interpret it. Sometimes now this Staph aureus is there, but it may not be the pathogen. But you can get E. coli sometimes. You can get Klebsiella. So it all depends on the microbial milieu in the area. But if you isolate a primary pathogen, that is significant, and you have to give antibiotics to cover that. Right. So you have to interpret in relation to the patient's condition. Okay.
Yes. Yes, sir. That's right. So I think we have encountered all questions that has mentioned asked from the audience, I think. I think in absence of further questions, I think we can stop this presentation.
Yeah.
But you, yes, again,
Alex,
thank
are you going to stop now?
Yes, we're going to stop
Yeah.
now. And Nandika madam?
Alex, Mahen sir will do the thanks.
Okay, sir.
Right. Okay. Okay. Thank you very much. Dear friends and colleagues, on behalf of the Sri Lanka Sepsis Alliance, thank you very much to everybody who attended today's webinar on maternal sepsis. Along with our partnering organization, we want to say big thank to Dr. Roshana for delivering an excellent presentation on maternal sepsis, Dr. Alex for a great case presentation, and all other resource person for sharing their valuable expert knowledge. We also truly appreciate all the participants who joined the online webinar today. Your support is very important to our work in saving lives and improving patient care. Thank you very much.